Good afternoon, everybody. I'm going to begin now. People will continue to join us, but in the interest of trying to preserve as much time as possible for discussion, let's start. I'm Deborah DeBruin. I direct the Center for Bioethics at the University of Minnesota, and I really want to welcome you all to the latest edition of our Ethics Grand Round series. We're here to talk about understanding the health and well-being of sexual and gender diverse populations today. Let me begin by talking through just some housekeeping items. If you have questions for the speaker or speakers, I should say, please use the Q&A function, which you will find at the bottom of your screen. We'll monitor those, the Q&A function, and address those questions all after the talk, not during, but it's okay for you to put in questions at any point in time during the talk, and we'll get to them when the talks are over. If you have technological issues, please use the chat function, and Center for Bioethics support staff will address those problems with you privately. For students who are seeking for biomedical engineering students who are seeking ethics credit for attending this grand rounds, you can email the Center for Bioethics main email address, which you see there on the screen, indicating your attendance. And for health professions students who are seeking interprofessional education credit, there will be a link available in the chat for completing the reflection to secure that credit, or you can also just email the Center for Bioethics main email address, and we will get back to you and help you to do what you need to do to get credit. Next slide, please. So I want to thank our co-sponsors. We had a lot of support in bringing this event to you today, and the center is really grateful for the support of these partners: the National Center for Gender Spectrum Health, the Clinical and Translational Science Institute, the Institute for Sexual and Gender Health, the Center on Women, Gender, and Public Policy, the Gender, Women, and Sexuality Studies Program, the Med School, and the School of Public Health. All are valued partners, and we want to thank them and acknowledge them. Next slide, please. So without further ado, I want to introduce our speakers for today. We're really grateful to have them both here with us to talk to us about this really important topic. So we'll start with Dr. Kellen Baker, who is the Executive Director of the Whitman Walker Institute, the Research, Policy, and Education arm of the Whitman Walker Health System. Previously, Dr. Baker was a senior fellow at the Center for American Progress, where he worked on health and data collection policy at the federal and state levels, and founded the Out to Enroll campaign, which helped the Affordable Care Act have uninsurance among low-income LGBTQ people. Dr. Baker currently serves as a consultant for the National Academy of Sciences, Engineering, and Medicine on a study assessing the health and well-being of LGBTQI+ populations, and is an appointed member of an Academy's Consensus Study Committee convened to develop standards for the collection of sex, gender, and sexual orientation data for the NIH. Dr. Baker holds a PhD in health policy and management from the Johns Hopkins School of Public Health, an MPH and MA from George Washington University, and a BA with high honors from Swarthmore College. Our second speaker today is Dr. Catherine Dahlk, who is a psychiatrist who specializes in mental health of adolescents and adults who are LGBTQ or have intersex traits. Dr. Dahlk provides clinical care at the Pennsylvania Psychiatric Institute and Penn State Health Hershey Children's Hospital. Dr. Dahlk is an assistant professor in the departments of psychiatry and behavioral health and humanities at the Penn State College of Medicine, where she also directs the Office for Culturally Responsive Healthcare Education. She has served on the Consensus Committee for the report Understanding the Well-Being of LGBTQI+ populations at the National Academies of Sciences, Engineering, and Medicine, and is currently serving on a Consensus Committee conducting a follow-up study on the measurement of sexual and gender diverse populations at the National Academies. Dr. Dalk also serves as a member of the Sexual and Gender Minority Research Office Working Group at the National Institutes of Health and on the Pennsylvania Governor's Commission on LGBTQ Affairs. She is a graduate of Haverford College and the Perelman School of Medicine at the University of Pennsylvania, from which she earned her MD and a master's in bioethics. She completed her psychiatry residency training at the University of Pennsylvania. We are so grateful that you both are taking the time to meet with us today to talk to us about this important National Academies report. And at this point, I'm going to turn it over to you, Dr. Baker.
Thank you so much, Dr. DeBruyn. We're both very excited to be here. I'm going to share my screen, and we really appreciate those introductions. And I would like everyone to note that Dr. Dalk may be the real bioethicist here in the room. I am just a wannabe, but she's not as hip as I am, because you could see I actually had my Twitter handle on my bio. So without any further ado, I'm going to launch into our presentation today on the well-being of LGBTQI+ populations. The objectives for our conversation today are to summarize how this National Academies report interprets the major drivers of LGBTQI+ health outcomes, identify some of the ethical themes that emerge in LGBTQI+ population health research, and appreciate the impact of the National Academies report on ethical debates in intersex care. Earlier this week was Intersex Awareness Day, so we're going to be spending the second half of our presentation today focusing on some of the ethical issues that arise in intersex health. I need to disclose, though you've already heard, that I am a consultant for the National Academies on this study. Dr. Dalk has no conflicts to disclose. So understanding the well-being of LGBTQI+ populations, this is a report that came out of the National Academies in 2020. The National Academies help policymakers and others make informed decisions by providing authoritative evidence. They are independent nonprofit institutions, so they are not part of the US government. They do, however, receive support from various government agencies in the form of contracts to work on projects of national importance. The particular study charge for this report came from the National Institutes of Health and the other sponsors. The Committee on Population at the National Academies will undertake a consensus study that will review the available data and future research needs on persons of diverse sexualities and genders, e.g. LGBTQ+ and MSM, or men who have sex with men, as well as persons with differences in sex development, sometimes known as intersex, along multiple intersecting dimensions and across the life course. This report really came out of a desire to expand upon the 2011 Institute of Medicine report on the health of LGBT populations in a couple of different ways. First, we recognized that after almost a decade, there had been an explosion of research, new evidence in the health of LGBT populations, and wanted to update the available evidence, sort of the summary of the available evidence, to reflect all of the incredible work that has been happening over the last several years. Second, to expand the populations, the Institute of Medicine report was on LGBT health. The current report is on LGBTQI+ health. And this really reflects the perspective of the National Institutes of Health. The Sexual and Gender Minority Research Office at NIH focuses strongly on intersex as being included under this broader LGBTQI+ or sexual and gender minority population umbrella. And finally, to expand what we meant by health. Many of us, particularly those of us from public health backgrounds, recognize that a great deal of what impacts our health and well-being actually happens outside the doctor's office. It is our environment, the context, the circumstances in which we live our lives. And so wanting to make sure that this report covered a wide variety of domains that affect the health and well-being of LGBTQI+ people. A quick note on the use of the term sexual and gender diverse. This term reflects that understandings of sexual orientation, gender identity, and intersex status, and the terms that we use to describe them, continue to evolve. An alternative is, of course, sexual and gender minority, which is used by NIH. This committee chose to use the term sexual and gender diverse in order to acknowledge, reflect the broad spectrum of natural human variation in sexual orientation, gender identity, and sex development. As I mentioned, a major purpose of this report is to look beyond just the immediate domain of health and look at other areas of well-being. So this report focuses on 8 different domains of well-being, which I will be going through at kind of a whirlwind pace. So hold on to your hats as we take a whirlwind tour of these 8 different domains of LGBTQI plus population health and well-being. The report also discusses demography and the current state of data collection on sexual orientation, gender identity, and intersex status. So I'm going to start with those. Demography is, of course, the basic understanding of who populations are, and understanding demographic trends is critical to guiding efforts to addressing disparities and improving well-being for LGBTQI plus populations. As all of us are likely aware, the visibility of LGBTQI plus and other sexual and gender diverse populations is increasing in the United States. Social climates around sexual and gender diversity are generally improving, but this is, of course, not a uniform trend, and it still varies quite a bit by aspects of, for example, where one lives in different parts of the United States. Demographic analyses of the LGBTQI plus population are complicated by factors such as rapidly changing trends within these populations. LGBTQI plus populations, as evidenced by sources such as the National Gallup poll, are becoming younger, more racially diverse, and more likely to include bisexual people, particularly bisexual women. And these are in particular some of the groups within the LGBTQI plus population where we see some of the worst disparities in areas such as economics and health, which I will talk about shortly. Also very aware that fluctuations in political and legal environments can make it unsafe or uncomfortable for people to self-identify as LGBTQI+. In fact, we really still don't know exactly how many LGBTQI+ people there are in the United States. The Gallup poll gives an estimate from 2020 of about 5.6%, which is over 11 million people who identify as LGBT, and an estimated 1.7% of people are born with an intersex trait or an intersex variation, but we don't really know because there is still this widespread lack of data collection on sexual orientation, gender identity, and intersex status. So we don't really know how large these populations are or the degree to which the changes that we may be seeing are due actually to changes in the number of people identifying as LGBTQI+, or simply the ability of more people to feel comfortable identifying themselves as such. Looking now at data collection and research, as I mentioned, there are substantial gaps in data collection around LGBTQI+ populations. In particular, these variables are not often included in data systems such as public and private population surveys, clinical trials and other research studies, administrative data systems, for example, applying for programs such as SNAP or Medicaid, and electronic medical records. Many of the efforts that are out there focus on same-sex couples. For example, the census only collects data on same-sex couples, not on sexual orientation per se. And gender identity is often poorly measured, while intersex status is almost never measured at all. And Dr. Dalk will talk about that in more detail. So these gaps in data collection and research are really the impetus for the current study that Dr. Dalk and I are part of to develop these standards for the collection of sex, gender, and sexual orientation for NIH. So looking now at the different domains of well-being, we're starting with law and legal systems because of the foundational role that these systems play in structuring the health and well-being of LGBTQI+ populations. Overall, the treatment of sexual and gender diverse people in the US legal system has improved over the last 20 years, but again, that is not uniform. There are still a number of gaps in the existence of and enforcement of legal protections, and these gaps particularly harm people of color, transgender people, and low-income people. A lot of the laws and policies that relate to sexual orientation, gender identity, and intersex status raise some particular ethical questions. For example, the only federal law that has ever been passed to include protections, explicit protections, on the basis of sexual orientation and gender identity is a hate crimes law. So the use of hate crimes laws to criminalize discrimination towards LGBTQ people raises some questions about how do we ensure that we are not inviting additional police presence into communities, into neighborhoods, to affect people who are already over-policed and over-surveilled. The scope and application of non-discrimination protections, including religious exemptions. This is a major topic of conversation now in the United States as non-discrimination protections have moved forward at the local, state, and national levels. There is increasingly attempts to carve out spaces for religious exemptions. These religious exemptions laws already exist. Religious Freedom Restoration Act is one of the major ones at the federal level. And so the relationship between these religious exemptions and non-discrimination protections is a particularly fraught area. And finally, although this is not an exhaustive list, bodily autonomy and barriers in access to services such as gender-affirming care and reproductive health care. So a lot of intersection with current debates about access to services such as abortion. Looking now at public policy and structural stigma, which affects people through the mechanisms of culture, politics, economics, and other levers of power. This is important in terms of thinking about where discrimination and mistreatment towards LGBTQI plus people comes from. We're sometimes encouraged to believe that it is a handful of bad actors, that if we could just deal with interpersonal issues between people, then there would be no problem of discrimination against LGBTQI plus people. But the framework of structural stigma says otherwise. It notes that stigma is built into systems of power and is exercised in a couple of different ways. For example, domination and exploitation, keeping people down, norm enforcement, keeping people in, and exclusion, keeping people away. So anti-LGBTQI plus bias operates through, for example, levers of government power and has these effects on making it difficult for LGBTQI plus people to access the resources, benefits, protections they need. We need a lot more research on the manifestation and effects of structural stigma. And it also raises questions about if stigma is being exercised through these levers of power, such as government, what does that mean about, for example, electoral power? Should we only advance policies that are socially and politically acceptable to majority voters? Who is the majority? That requires us to think about how is power being wielded and by whom. Looking now at community and civic engagement, access to affirming and safe physical, virtual, and social spaces is essential. Community has a number of roles that it can play in fostering well-being and resilience among LGBTQI plus people. Many of us are likely familiar with celebrations such as Pride Month that happen in many parts of the US in June. But something to note specifically about community in terms of LGBTQI plus populations is the continuing issue of segregation, the ways in which people do not have equal access to the safe spaces that exist, that remain for LGBTQI plus people on the basis of factors such as race. I apologize. Coming off a cold, and all of us post-COVID, none of us have immune systems anymore. So apologies for that. Looking now at families and social relationships, which are critical to the development and well-being of anyone, but have a particularly salient role for LGBTQI plus people. For many sexual and gender diverse people, family and social relationships can be strained, which is associated with negative health consequences. Some of the specific ethical issues that arise related to family and social relationships for LGBTQI plus people include access to assisted reproduction and other family planning technologies, autonomy in relationships between children and adolescents and their parents or guardians, and social, political, and legal perspectives on relationships and parenting among sexual and gender diverse adults, the degree to which people, particularly as adults, have the right to organize and conduct their own lives the way they desire, and thinking about the ways in which the US legal system has often been used to try to circumscribe that. Education and economics. Many sexual and gender diverse people experience poor treatment in education environments and a lack of economic opportunity throughout their lives. So kind of tied together here in socioeconomic status. LGBTQI plus students often encounter bullying and harassment from peers and teachers in educational settings. This is unfortunately one of the best documented disparities affecting LGBTQI plus people, is the degree of harassment and bullying that occurs in educational settings from kindergarten all the way through higher education. Once people are out of the education system, many people continue to endure reduced access to resources, to have a harder time navigating systems such as finding a job, dealing with issues of employment discrimination, what that means with regard to people's income, ability to build wealth, and how that intersects with racial disparities in the United States. There are also disparities in access to credit and housing, as well as to public assistance and means-tested services. And LGBT people, broadly speaking, are more likely than heterosexual cisgender people to use public benefits such as SNAP. And so making sure that there are non-discrimination protections in place to ensure that people can access these services and benefits is something that is still a matter of substantial discussion at the state and national levels in the United States. The effects of a 2020 Supreme Court decision, this was the Bostock decision, which found that Title VII of the Federal Civil Rights Act prohibits employment discrimination against LGBT people. That law says that discrimination on the basis of sex is prohibited. And this Supreme Court decision from 2020 expressly interpreted sex to include sexual orientation and gender identity. But the effects, and in particular, enforcement of this law across the country and how that will change or might change economic disparities affecting LGBTQI plus people remains to be seen. And looking finally at our last two domains, you can kind of tell the health people were in the driver's seat of this report. So there are two chapters or two components of health that we look at as separate domains. The first is physical and mental health, recognizing that sexual and gender diverse populations face numerous and persistent physical and mental health disparities. These disparities are driven by social forces such as stigma and discrimination. They are not inherently related to sexual orientation, gender identity, or intersex status. This is, of course, a great difference from our understanding of these disparities, for example, maybe 50 years ago, where sexual orientation, identity as lesbian, gay, bisexual, for example, was treated as a mental illness. And in some ways, identification as a transgender person is still treated as a mental health concern rather than an aspect of identity. These disparities are also unevenly distributed according to factors such as race and gender, and they are compounded by racism, by sexism, by all of the ways in which LGBTQI plus people are not just LGBTQI plus. They come from all kinds of backgrounds, different racial backgrounds, ethnic backgrounds, language backgrounds, ability, geography, religion. All of these different intersecting factors can unfortunately compound for disparities for LGBTQI plus people who live at the intersections of multiply marginalized communities. Most intervention research in LGBTQI plus health has focused on HIV, and more work is needed both in that area. The HIV epidemic continues to take a disproportionate toll on LGBT people, particularly gay and bisexual men and other men who have sex with men, particularly men of color, and transgender people, particularly transgender women of color. But more research is needed on effective individual and structural interventions for other health concerns as well. And then looking at access to evidence-based health services, sexual and gender diverse populations need access to a full range of evidence-based and high-quality preventive, chronic, and acute healthcare services that are delivered in welcoming and affirming environments. The committee looked specifically at three different health services. These really shouldn't be bucketed together necessarily, but looking at sort of three particular considerations when it comes to access to evidence-based health services for LGBTQI plus people. The first is looking at gender-affirming care, including puberty delay medications, mental health services, hormone therapy, and surgeries. The committee found in its review of the literature that gender-affirming care is associated with improved mental and physical health for transgender people and should be covered by public and private insurance. On the contrary, there are two other interventions that are not evidence-based that are dangerous to the health and well-being of sexual and gender diverse people and that should not be performed. And these are conversion therapy to change sexual orientation or gender identity, and as you will hear about in more detail in Dr. Dahlk's presentation, elective genital surgeries on children with intersex traits who are too young to participate in consent. So looking at this entire corpus of evidence, it's a much more substantial, as I mentioned, even than it was in 2011 with the Institute of Medicine report. And so the committee distilled these 5 recommendations from that body of evidence. The first is collecting data, actually adding these variables, sexual orientation, gender identity, and intersex status measures to surveys and other research and data collection instruments and systems. Also looking at the same time at improving measurement and filling data gaps, making sure that the measures that we're using are up to date with the terminology that people are using and are actually reflecting the constructs of interest. That's something that Dr. Dahlk and I and the rest of the committee that's working now are taking a very hard look at, making sure that we are identifying the specific constructs of interest in research and data collection. Facilitating data use by making better use of the data that we have. And of course, remembering that the point of all of this is not simply to collect data for the purpose of collecting data. It's actually to use these data to build evidence-based programs, policies, interventions, budgets that can respond to the needs of LGBTQI plus populations and help address disparities. There are a number of ethical considerations in sexual orientation, gender identity, and intersex status data collection. What kinds of data are being collected, by whom, how are they being collected, and why? And we will be very happy to talk about any of these considerations or others that may be top of mind for you in the Q&A portion of our presentation today. But without any further ado, I will turn it over to Dr. Dahlk to take us on a deep dive into intersex health, history, outcomes, and ethical debates. Dr. Dahlk?
Thank you so much, Dr. Baker. I really appreciate the all the work that you did and the phenomenal way that you presented that information. And I will completely agree that you are definitely hipper than I am. So I will happily see that. We wanted to spend some time focusing more specifically on intersex health. As Dr. Baker mentioned, this is the week of Intersex Awareness Day, which is was Tuesday, October 26th. And as we talk through the focus on intersex health, part of what I'm hoping to convey to you all is, number one, just how significant the findings of this report were within the broader history of intersex management and the intersex advocacy movement, but also to lay out what some of the ongoing ethical controversies and debates are that are pertinent to folks with intersex variations. So just to kind of take a step back, to be very clear, the way we're thinking about intersex traits are as a group of congenital or inborn variations in sex characteristics. These sex characteristics include sex chromosomes, hormones, internal and or external genitalia. And the way that we define variation is specifically relative to endosex traits. So what I mean by endosex traits are the sorts of physical sex characteristics that we tend to think of as being associated with someone who is male or someone who is female. So we use the term endosex both to highlight that everybody has a sex, but also as an opportunity to say we're comparing folks who are intersex to folks who are endosex, rather than comparing folks who are intersex to folks who are normal. So it's a similar analogy as cisgender is to transgender. Some people who have variations in particular in the hormones their body produces or their internal genitals may also have some variations in their secondary sex characteristics, like the pitch of their voice, hair patterns, breast tissue, etc. While sort of most famously intersex traits present at birth, it turns out that intersex traits can present at any point along the lifespan. Most commonly present in early childhood or at birth, but often also in puberty. And some people are not identified as having an intersex trait until well into adulthood or even older adulthood. Intersex traits are commonly thought of as being very uncommon. And when we think about the narrowest definitions of intersex variations, which are folks who are born with visible difference in the appearance of their external genitals, that's a pretty uncommon situation, affecting somewhere between 1 in 2,000 to 1 in 4,500 people. However, if we take a much broader definition of intersex, which is any variation in sex characteristics, that can happen in as many as 1 in 58 people, or the 1.7% statistic that Dr. Baker referenced earlier. The language that we use generally in the report, and that I'll use generally today, is intersex populations or people with intersex traits. Although there is a lot of other nomenclature out there, the most frequently used of which is DSD, that is often read out as differences of sex development. So as we start to think about what health outcomes are for intersex folks, one of the things that we found as we were working on the report is that really the current evidence regarding health outcomes and the research base is heavily influenced by the historical approach to intersex. So if you'll bear with me, I'm going to do a very broad sweeping overview of historical management of intersex variations. And if you're interested in learning more about this, I'm happy to provide additional recommended reading. So essentially, we can group the history of intersex into 3 broad eras. The first is prior within the US. The first is prior to the 1960s, which I think of as the pre-medicalization era. And prior to the 1960s, there were very limited diagnostic tools, for example, to be able to identify someone's karyotype or to identify what their gonadal tissue was, to be able to offer a specific diagnosis for someone with sex variation. So there were many people who were never identified as having a sex variation if their genitals were appeared to be endosex. For folks who did have diverse genitalia, there were limited surgical options available for those folks. So many people just sort of grew up and lived their lives without significant medical treatment, although there is significant reports of people experiencing social stress and stigma to this. However, it is important to note that as sort of the cultural capital of medicine increased over time, physicians were sometimes called in actually by the courts to verify the sex of someone in the case of a dispute over marriage or inheritance or something where sex was really relevant legally. In the 1960s, we saw this sort of rapid explosion in the medicalization of intersex variations. And this we can really think of as being driven by advances in transgender care. As transgender people and transgender needs became more visible in the US, there were 2 things that happened that were very pertinent for intersex folks. The first was that we saw way more providers becoming trained in and learning about gender-affirming surgeries, being able to change the appearance of the external genitalia. But within the world of psychology, there was also this growing awareness that there was a difference between gender identity or gender role, as it was described then, and physical sex. The other thing that I think was understood and was very heavily couched in sort of the zeitgeist of the 1960s was this idea that we had an obligation to provide people a normal life. And physicians really looked at these advances for intersex folks as an opportunity to protect people from social stigma and provide them a normal life. The experiment that really laid the groundwork for intersex management throughout the 20th century was published as the John Joan experiment, who we later knew were identical twins who were named Bruce and David Reimer. So the basic story here is in Canada, there were 2 identical twins born, both assigned male with endosex male genitalia. And one of the twins underwent a circumcision that involved electrocautery. And the machine malfunctioned and the child's penis was really badly burned and had to be amputated. Around the same time, there was a psychologist in Baltimore, Dr. John Money, who was conducting research on this idea that sex was different than gender, and that gender was probably more heavily determined by nurture than it was by nature. So the family took these children to see Dr. Money, and Dr. Money recommended that the child who had had the penile amputation be raised as a girl. And this was sort of an ideal experiment in the sense that you had identical twins in the same social environment, and was published as a successful gender assignment procedure. So the girl, Joan, who later we learned was Bruce Reimer, had surgery to create a vagina, was raised as a girl, and was published as identifying as a girl and being interested in boys. We found out in the 1990s, actually, that Dr. Money's methods in this experiment, to say the least, were really suspect and unethical. And it also turned out that it was not the success that everybody had expected it to be, that later in life, that Bruce had sort of come out and lived his life as a man. Both of the twins actually developed substance use disorders and both died from suicide. So it's a really, really tragic story for this particular family, and also had what I would argue are really substantial consequences for intersex people throughout the 20th century. Because how people interpreted this study specific for intersex folks was that you could assign a gender identity at birth, and as long as the person had surgery early enough before their gender identity otherwise consolidated, they would identify with whatever gender you assigned. At the same time, however, it was really essential that all information be withheld from that person so that there was no risk of confusing or complicating the gender assignment. The other thing that I think is important to note, as I told you in the John Jones stories, the reason this was understood as being so successful is because this was a child with a vagina who identified as a girl and liked boys. So we saw this projection of cis and heteronormative values onto gender assignment that also played out for intersex children, because the number one factor for many years in assigning gender was, are these genitals ones that can be more easily created to look like a vagina and a vulva, or a penis? So it wasn't until the 1990s that there was organized and clear questioning of the ethics of this care paradigm that really was a credit, number one, to the discrediting of the John Jones story, but also to the rise of intersex activism. And in the 1990s, people had access to the internet. They were able to connect to each other online. And this was the first time that groups of people who had been effectively driven underground by prescribed concealment and secrecy were able to connect with each other in activism and support groups. And the narratives that emerged from those communities were ones that highlighted significant physical complications from early surgery, pain, sexual and urinary dysfunction, as well as psychological complications of shame, secrecy, and stigma. It was also in the 1990s that we began to see this call to a pretty aggressively demedicalized sex variation, but I would also argue to start to queer sex variation in a way that was seen as being empowering. So it's really interesting is we have this transition from children are at risk of being queer if they have sex variation, and therefore we must make them normal, to activists in the 1990s saying, no, we're actually going to borrow from the LGBTQ rights movement to queer sex variation and make some of the same cases. And the image on the right there speaks directly to this. The first intersex protest was held on October 26, 1996 in Toronto at the American Academy of Pediatrics. It was jointly organized by a group called Hermaphrodites with Attitude and the Transgender Menace. And you can see here Max Beck, who was an intersex activist, is holding a sign that says silence equals death, which was one of the major sort of slogans of the AIDS activism movement in the 1980s and early 90s. As a result of activism and narrative, we did start to see some gradual changes in medical care, making more sort of thoughtful gender assignment, working in teams, routinely disclosing diagnoses, and a bit more surgical caution. But really what has persisted as we have this ongoing sort of conflict between medicalization and demedicalization in the intersex movement is when, if at all, should surgery be offered? And if surgery is offered, who gets to make the decision about what the surgery is and what the surgery does? So as we transition back to the report's findings, we actually found that this history of medicalization and non-disclosure had significant impacts on the research base. So what's really fascinating about that is while we found robust evidence for LGBT people in population and public health research, for intersex folks, the research is almost exclusively drawn from clinical samples, focused on outcomes from medical or surgical interventions. There's a really heavy focus on the mental health of parents, especially of intersex infants and young children. There's almost no population level data. As Dr. Baker mentioned before, it turns out this is because intersex status is almost never assessed alongside sexual orientation or gender identity data. And also because a lot of intersex folks may not know their intersex status because of the history, or may have been told that this is something they need to keep from other people. And I think also really interestingly, we found that while a lot of our data, for example, on bisexual people is seen as a sort of subgroup analysis, looking at LGBT communities more broadly, they'll do a separate analysis of people who identify as bisexual from that sample. Intersex folks are almost never included in LGBTQ+ health research. There is, however, some evidence from these clinical samples of health disparities that I think are important to point out. Cardiovascular and cancer risk varies by a particular intersex variation or difference of sex development. Variations in sexual function and fertility seem to cut across variations of sex development. And so some of that may be related to a particular person's anatomy at birth, and some of it can be a consequence of the treatment that person had. There is very consistent evidence of higher rates of depression, anxiety, and stigma in social, sexual, and medical settings. And also consistent evidence that people are much more likely to identify as not cisgender and not heterosexual if they have an intersex variation. Just as a point of comparison, the best data that we have right now suggests that somewhere between 0.6 and 1% of the US population identifies as transgender or has a trans experience. Whereas when we look at intersex populations, between 10 and 25% of people identify as transgender or have a trans experience. There's almost no data at all regarding experiences of violence, suicide, or substances among intersex populations. So I'm going to speed up here just to say that after we published the report, there were additional studies published that started to answer actually some of the questions that we had. We saw more data emerging regarding higher suicide attempts, and also more data emerging regarding higher rates of discrimination as far as housing, access to medical care, and financial circumstances. There was almost none of this data available when we wrote the report. When we look at parental stress, we find in particular that parents of children with intersex traits experience high rates of distress, depression, and anxiety, and even PTSD symptoms. And really fascinatingly, this is one of the major factors in decision-making for surgery early in life. Surgical studies actually look at parental stress as a direct outcome of surgery. There's also evidence that's been emerging that suggests that physician perception actually guide parental decision-making, partly because of this stress. So physicians are more likely to rate a child's genitals as looking abnormal than their parents are. And there's also evidence that physicians may guide parents towards the decision that they perceive as recommended when there's uncertainty. So this is really why this is a major, major, major shift in intersex health, which is to say that when we look at some of these health disparities, they're not driven by a person's medical variation, but they're also driven by social forces, and they're not specifically inherent to the person. And also really highlighting, again, this lack of research that explicitly includes intersex folks. So just wanted to bring this back to highlight that. I think the other thing that, as we start to think more broadly about the ethics of intersex care, what I would argue is that this historical approach to intersex variations was really motivated well. It was motivated by the desire to give people a normal life and to protect them from stigma. But as we are looking at this data, I think what we're starting to see is that intersex health disparities today seem to be driven in part by stigma. And so the question is, does surgery actually improve physical or mental health? Does it actually reduce stigma? Does it accomplish what it seeks to? So within the report, we spent a significant amount of time describing the physical risks and benefits of different kinds of surgery. There are three major groupings of surgery that we looked at. One is gonadectomy, or the removal of tissue that may be testicular, ovarian, a mixture of both, or perhaps that is dysgenetic, meaning that it hasn't differentiated as testicular ovarian. feminizing surgeries, which seek to reshape or create a vulva or vagina, or to shorten the length of a clitoris, and masculinizing surgeries, which seek to move a urethra from the underside of the penis to the tip, or to create a phallus. And it turns out that these surgeries do have some evidence of benefit. They do, for example, gonadectomy can reduce the risk of cancer if a person is at risk of gonadal cancer. They can make genitals look more normal. And they can, endosex, I should say, and they can also help create genitals that are more capable specifically of penovaginal intercourse, assuming that that's what someone wants. However, there are significant physical risks that we saw. Specifically, there's growing evidence that folks with intersex variations may have a greater capacity for fertility than previously thought, which amounts effectively to sterilization. And also we see significant risks of reoperation, sexual dysfunction, urinary problems, and scarring and pain after feminizing and masculinizing surgeries. When we looked at the social and emotional outcomes, what we found is that there really is mixed and almost no evidence that these surgeries have social and emotional benefits. And that is specifically because the studies that consider social and emotional benefits really lack a non-surgical comparator group. So for example, there are studies that show that people in adulthood, when they're asked, are you glad you had surgery, say, yes, I am glad that I had surgery. And we see that parents are less stressed after surgery. However, again, we don't know what would have happened if that person hadn't had surgery. There's also been some evidence that treatment can actually reinforce stigma. And as we've talked about, some evidence that bias can actually influence a parent's adaptation and decision-making. I think gender congruence is a really major consideration, as we've talked about, because so many people identify not as cisgender. I will say that as we've learned a lot more about individual variations, we've been able to decrease the likelihood that we will make a wrong prediction. However, there are still significantly elevated risks and rates, I should say, of non-cisgender identification. And when we're talking about genital surgery, we're talking about interventions that are largely irreversible. Also, really interestingly, over the last 5 to 10 years, there's been growing international attention to the human rights of children with intersex variations, and specifically looking at whether these surgeries pose threats to a person's right to body and genital autonomy and an open future. The United Nations has actually identified early genital surgery as a form of medical torture, which is really interesting and strong language. And I think also within the theme of the overall report is this question of, do these surgeries actually affirm diversity in the way that we seek to increasingly societally? I do want to acknowledge that there are a number of professional societies that argue that this decision should still rest with parents because it falls within this ethical construct of the zone of parental discretion. And in particular, that physicians and parents have an obligation to promote the autonomy of the child in decision-making through assent and shared decision-making. So you can see how these groups are trying to thread that needle between autonomy and parental choice. There are also a number of organizations, however, that have recommended delay. The ones in black were listed in the report. The ones in orange have actually come out since the report, including 2 children's hospitals in Chicago and Boston, and then the New York City hospital system. So the conclusion that we as a committee came to is that early surgery seems to be associated with mixed evidence of physical benefit, really scant evidence of psychosocial benefit, and strong evidence of harm. And in particular, as we considered the infringement on human rights and the ways in which this sort of intersex exception seemed to countervail everything else we were seeing about how affirmation of sexual and gender diversity improves well-being, this is how we came to the conclusion that elective genital surgeries on children with intersex traits who are too young to participate are dangerous to the health and well-being of sexual and gender diverse people. So as we start to wrap up here, I think the questions that we are really left with is, is elective surgery for intersex children really distinct from other instances of pediatric decision-making? Is it the same thing, for example, as making a decision about another kind of surgical treatment that a person might have? Do we construct beneficence and non-maleficence differently in the world of sexual diversity, particularly as society's attitudes towards an understanding of these things are evolving? I think one of the other things that's really fascinating is that to be able to answer some of these questions, we really need to be able to compare children who have had surgery and children who have not. And if we think that surgeries are potentially harmful, how do we collect that data ethically? Particularly if more and more institutions start to move towards recommending against surgery. And then I think the other thing that's fascinating is that from the last 30 years, the highest level ethics question in intersex care is, should we do genital surgery? But I think as we start to move into this new era, one of the things that I'm really starting to increasingly wonder is genital surgery actually the highest priority ethics question when it comes to intersex health and well-being? Or should the question be, what is our role, not necessarily even to promote autonomy, but what is our role to very proactively reduce stigma and affirm sexual diversity and to empower people? So with that, I think we will transition to the Q&A. I'm not sure if I should stop sharing my screen at this point, so I'll look for guidance from the UMN folks here.
So if you could leave your screen up for just one more second while we remind folks that they can certainly use the Q&A function to submit questions, and we'll address those questions now, but it is not too late. So feel free to continue adding questions in the Q&A function. There will be an evaluation that pops up in your web browser, participants, after the event. And if you don't have time to do the evaluation right away, we will also send you a link via email after the event. And just a reminder, biomedical engineering students and health profession students who are seeking interprofessional education credit, you can email the Center for Bioethics. And this session is being recorded and will be posted to the center's website shortly after the event ends. So for those of you who know someone who might be interested in seeing these amazing talks and hearing the conversation that is about to ensue, there'll be an opportunity for that. So I think you can stop sharing your screen right now, and we'll just move to the Q&A portion. Thanks. I want to start. I think there were some questions that were submitted prior to the talk as people were registering and as we were talking with our co-sponsor partners about this upcoming presentation. And I see that there are also questions in the Q&A. So let me start with something that is, I think, fairly foundational, and that's the sort of question about numbers in a way. I see that there were some questions about data that got posted to the Q&A that Dr. Baker, I think, already answered in the Q&A function. But there in the description of the report that was posted in the materials for this talk, there was a claim that there are more LGBTQI people now than there have been in the past. And I know that you addressed this to some extent in the talk, and it does get addressed to some extent in the report as well. But could you speak to those issues about how do we do data collection and how do we understand demographics when there are real questions about people's comfort level identifying as LGBTQI and so on?
Yeah, thank you for that question. And I did put in the chat or in the response to questions, and I can put it more broadly in the chat, the link to the Gallup poll that was released in February 2021 that has that figure of 5.6% of US adults identifying as LGBT. It also has a breakdown over different ages, which is a part of the origin of the saying that there's an increasing number of people. The US population is continuing to increase, which means that there are more LGBTQ people. Whether or not there are larger proportions of people who identify as LGBTQ or intersex is a question that remains open. As I was mentioning during my presentation, we do not have any nationally representative surveys that consistently ask about sexual orientation, gender identity, or intersex status. So the numbers that we have really have come from private sources such as the Gallup poll. There have also been some more statistically oriented efforts to extrapolate population numbers from, for example, surveys such as the Behavioral Risk Factor Surveillance System, which asks a question about sexual orientation and gender identity in about 38 states now. So that's about 75% of the US population. But there really is a need at the national level in particular for these surveys that give us these snapshots of the US population, the American Community Survey, the National Health Interview Survey, the census, to add questions about sexual orientation, gender identity, intersex status that are capable of giving people the opportunity to identify themselves. And I think that's really a core component of this. Is no one, I think, would argue, or certainly Dr. Dalk and I would not argue, that it is a requirement for anyone to disclose their sexual orientation, gender identity, or intersex status. But what we do think is that people should have the opportunity to choose if that is information they want to share. We've done a couple of research studies that look, for example, in healthcare settings and clinics, that people are more than happy. Certainly, we found that cisgender and heterosexual people are very happy to share that they are cisgender and heterosexual. And indeed, LGBTQ people are also happy to share information about their sexual orientation and gender identity. There's a really interesting study in JAMA from a couple of years ago looking at disclosure of sexual orientation in the emergency room, so a very fraught area of the healthcare system, and found a stark difference between about 90% of clinicians believed that LGBT people would not disclose their sexual orientation in the emergency room. But in fact, only 10% of LGBT people said that they would not disclose that information in an emergency room setting. So we're seeing a really substantial difference in sort of the perceptions of people not wanting to share this information. It's too sensitive. It's something that shouldn't be talked about. But really, we're arguing, I think, for there to be the opportunity for people to share that information if they so desire, because it is relevant to healthcare, it is relevant in a lot of other areas, and it gives people the opportunity to share what can be some really important information about themselves.
Dr. Dahl, do you have anything to add to that? So let me ask you another question that really relates to sort of the language we use and has a connection to that idea about self-identification. So there are lots of ways, even today, that the populations that we're discussing have been referred to in the conversation. So there is the sexual and gender minorities. There's sexual and gender diverse populations, that language. There's the LGBTQI plus language. And one question that came in was about the reasons for using different labels or language to refer to the populations, and issues around choice of that language, and questions about when we should be using language that is the language of choice of the populations, and when it makes sense to use language that sort of fits with other sort of policy agendas, like, for example, the NIH's use of sexual and gender minorities as a way of sort of connecting study of this population to other minority populations that they want to promote research on. So if you could speak to that.
Yeah, I'm happy to take an initial crack at that, and I'm sure Dr. Baker may be able to help me out too. So I think one of the first things to say is that we as a committee actually really labored over that question in writing the report. You know, I've been involved in providing LGBTQ health for LGBTQ healthcare for about 10 years, and am in the community and sort of eat, sleep, and breathe this. And every day I hear language that I have never heard before and completely throws me off guard. And I think it can be really dizzying, and especially I think from a scientific perspective can be overwhelming. And at the same time, I also see this as a point of pride and celebration for the community, which is that we are constantly asserting our right to be able to self-identify, which I think is really important. As a committee, we used this language of sexual and gender diverse for a couple of reasons. One was because we did want to align with the sexual and gender minority language, but did not, I think, saw that there were problems in using the language of minority, right? So for example, when we're looking at even constructing racial and ethnic minority, that someone is only a numerical minority in a specific context, right? So Black and brown folks may be racial and ethnic minorities in the US, but they're not globally racial and ethnic minorities. So that, I think that was one of the issues that we thought about. And I think the other thing that we were really conscious of was that there's so much evidence that suggests that stigma is such a big driver of health issues that we didn't want to reinforce stigma in the language that we were using. However, we do not advocate that people use sexual and gender diverse as preferred language. That was language that we came up with and do not recommend that people use. And that's actually why the title of the report is Understanding the Well-Being of LGBTQI+ Populations, which in general is the most commonly used language. I think my recommendations to researchers in these circumstances are to be flexible in the language that you're using, certainly to use language that will have salience for the funder that you're working with, but to also, I think it's an opportunity to think about community-based participatory research and really engage people from the community and the work that you're doing, and engage them in crafting language to be inviting, welcoming, and inclusive. So that's very broadly how I think about this, and I realize that I may have sidestepped the question a little bit in so doing. I don't know, Dr. Baker, if you would add anything to that.
I think that's very helpful. Thank you. Very thoughtful response. So next question, there's so many questions, so I'm afraid I'm not going to get to them all, but let's do our best. How do we better promote awareness and advocacy of the validity of intersex status and or differences of sex development? How do we ensure that this awareness and advocacy around the biological reality of these differences of sex development do not unintentionally lead people to assume that there's also a biological basis for gender? In other words, how do we ensure that our intersex advocacy cannot be misused by people to discredit the legitimacy and validity of trans identities and the medically necessary nature of gender affirming care?
Yeah, I hope Dr. Baker doesn't mind me disclosing things from our personal conversations, but that's an existential quandary for both of us. We've actually seen this across the US with the rise in anti-trans legislation, where states that have passed laws, for example, that ban puberty blockers for trans minors, or say that Medicaid won't be covering gender affirming hormones or surgeries, have intersex exceptions in those laws, where basically they say, and on its face, it makes sense, right? Because you're saying if you have this medical diagnosis for which this treatment is necessary, we will provide it. But at the same time, it's a way of justifying violence against intersex people and the process of justifying violence against trans folks, right? So I think, you know, the principle that I keep coming back to in this is that at their core, intersex and trans movements are all about autonomy. They're all about centering the right of a person to make decisions about their bodies on the schedule and in the order and in the setting that they want and need that to happen. It's about a radical centering of autonomy in that way. So that principle, I think for me at least, has been very helpful in helping people understand how not to make things worse for one population when you're advocating for another. I also think that there are ways in which thinking about sex as a matrix and not as categories can also help validate the experiences of trans people, particularly because we do, I work in a gender health program for trans youth, and we see a lot of trans youth who come in who are identified as having intersex variations in adolescence who are coming in to seek care. And so there are actually ways that that thoughtful medicalization can actually really help validate the experiences of trans people and also liberate intersex people from these really rigid constructs. Dr. Baker, I don't know if there are other things that you think about in this space as well.
I love the radical centering of autonomy, because that really is what it's about for trans and intersex populations. And I think broadly speaking, this is about sexual orientation as well. Not just about who we are, but the types of behavior that we have, the types of relationships we want to build, and also thinking about reproductive justice and the ways in which so many of the movements in this country are focused towards shutting down or eliminating people's ability to make choices about their own bodies and their own lives, their relationships, their families. And so I really think that that's a common thread that cuts across so many experiences of not just trans and intersex people, but many, many communities and people in this country.
Thank you for that. Next question. The questioner says, I appreciate the consideration of access to evidence-based health services as they relate to gender-affirming care and so on. Is similar data available for what may be called common healthcare needs? That is to say, access to non-transgender specific healthcare, such as dialysis, primary care, chronic disease management, and so on.
Yeah, there is quite a bit of emerging research showing that transgender people have needs that are above and beyond what we think of as transgender health. That's one of the reasons why I in particular like to talk about gender affirming care instead of transgender care. You see a lot of, for example, insurance sort of coverage policies talk about transgender care. And I really think that that narrows the scope of what is actually this really broad topic of transgender people are people. So they need access to the same types of healthcare that anyone else does. And that includes, for example, preventive screenings. If you have the body part, you should get it checked out. It doesn't matter what it says on your insurance card or what it says in your medical record. And so that sort of narrowing of how we think about transgender people and transgender people's health needs to just gender affirming care, I think really does a disservice, because it makes invisible all of the ways in which transgender people move through their lives and need all types of healthcare services, just like anyone else. It also, I think, obscures the origin of a lot of the types of procedures and interventions that are involved in gender affirmation for transgender people. Transgender health or gender affirming care has never been sort of a hugely, let's say, remunerative field. People are in it because they want to provide healthcare services that are very hard in many cases to access. But in terms of where these procedures are coming from, it's all from, let's say, cisgender, call it cisgender medicine. Primarily, for example, genital reconstructive surgeries. Really, a lot of that work has its origins, for example, in the military and the Veterans Health Administration, the military health system, for people who have experienced traumatic amputations or traumatic injuries in war. And so the types of healthcare services that transgender people need, broadly speaking, are really the same as those health services that cisgender people need. And looking specifically at gender affirming care, those services are considered medically necessary and are routinely covered for cisgender people, indeed came from the field of, for example, nowhere near thinking about gender affirmation for transgender people. And so it really, I think, is important to underscore all of these similarities, all of the ways in which transgender and cisgender people very much have the same healthcare needs. And as the report notes, should be able to access comparable health insurance coverage for those needs.
So I'd like to follow up with a sort of a more general question that a number of our questioners have posed in one way or another to us, and that is the question about how should what recommendations do you have for how healthcare organizations or healthcare providers or public health professionals can incorporate the recommendations in this report and become more inclusive? So what recommendations would you have for them? And then the second part to that question is, we have a question which I think is very poignant from a parent who says, I'm a parent of a gender diverse child, and what are the most important things from this presentation for me to think about as I parent my child, in addition to just acceptance? So where do we go from here? A lot of people are looking for help to think about, how do we implement these recommendations?
So, my answer to this is going to be very heavily influenced by my experience as a psychiatrist. So please bear with me as I get into the feelings. I think, to me, one of the highest level conclusions of this is that LGBTQI plus people and communities are really resilient, and are also experiencing stress and stigma sort of at every turn and in every setting. And that one of the most important things that we can do is create spaces for LGBTQI plus people that are warm and welcoming and affirming. And so I think at a health system level, what that looks like is not just collecting data on sexual orientation, gender, and intersex status from every person who walks through the door of that health system, but also doing that in a way that is patient-centered and is used in a way to actually enhance a person's experience, right? So it's followed up with questions like, tell me what that means for you, tell me about your name, tell me about your pronouns, etc. I think at an individual level, for the parent, the same thing applies at the level of families. So there's really strong data that tells us that LGBTQ youth broadly, but also trans youth in particular, have pretty high rates of mental health distress in particular, and that the number one thing that seems to insulate those kids from problems are family support and acceptance. And there are phenomenal resources available online and in books about how you actually affirm and support a kiddo. But at the end of the day, I think, to me, the highest level takeaway from this is that, like, those of us in our families and who have influence on our health systems, we have an obligation to push against this cultural tide to create spaces for people that are supportive and affirming.
Yeah, and I would add, in terms of sort of how to incorporate this into our work going forward, I mean, one is just awareness of the fact that LGBTQI plus people exist. I am transgender and queer. We walk among you. You can't necessarily see us coming, but we are there, and we are. I think, want to use the language of, we are a growing proportion of the population. If you look at that Gallup poll that I shared, you can really see the increases in the number of young people in particular identifying as, for example, gay, bisexual, queer, transgender. And so I think looking for opportunities to make visible not just LGBTQI plus people, but also the heterosexist, the cissexist, the endosexist assumptions. There's, I think, a lot of work. It's often said, I think, in medicine, that we treat everyone equally. And that's a wonderful sort of value overall, but it really overlooks the fact that it's not actually necessarily a good idea to treat everyone equally, because not everyone's experience is the same. And so that's one of the reasons, I think, why there's been this shift from the language of equality towards the language of equity, because really needing to recognize that treating people the same often means imposing assumptions, as Dr. Dahlk was mentioning with the case with Dr. Reimer, or Dr. Money and the Reimer family, that they really imposed these heterosexist assumptions on these kids, and that had a really terrible outcome. And so thinking about, again, not just how to make visible LGBTQI plus people and concerns, but also recognizing the ways in which we are manifesting our own biases, our own ways of understanding the world, taking a step back and sort of thinking, what does this person need? Where are people coming from that might be different from what I would have expected? And to the question about from the parent of a gender diverse child, I'm really glad that you are here. I came out as gay in the early 1990s. It was really not that fun. And then I came out as transgender in the early 2000s, and it was, again, not that fun. And so having people, parents like yourselves, having conversations like this, your child will be fine. I think the support of family and friends is really the most critical piece for any young person, whether they're transgender or not. And so I think just asking those questions, looking for information, and just loving and accepting your child for who they are, that is really the most critical, most important thing that you can be doing.
Thank you. I really appreciate that. Those are both very thoughtful answers. And I'm afraid that we are over time. There are a lot more questions we didn't get to. There's obviously just a huge interest in the work that you are doing, and we're really grateful for it. I am particularly grateful that you talked about the equality versus equity issues at the end, Dr. Baker. The Center for Bioethics is focusing ethics grand rounds entirely on equity this year, as we did last year, because we think those issues are so important. And we are really grateful to both of you for being with us today to raise up these issues and to help us understand the findings of this National Academies report. So thank you. Thank you for your work.
Thank you for having us.
Yeah, we're very appreciative of being here and of this conversation. Thank you.
So just to remind folks, Ethics Grand Rounds in November will be on the equity implications of the rapid transition we had to reliance on telehealth during the COVID-19 pandemic. Should be another really interesting conversation, and we encourage people to join us. Thanks, everyone.